Okay, so today we're going to be talking about epidemiology. So I will let you know that some of the numbers in here are kind of old because it takes them a long time to process the NHANES data set. So NHANES is the National Health and Nutrition Examination Survey. It is a survey that goes out to a randomly polled representative sample of the population in the United States. It is long. It has a lot of sections on health, like whether or not you visit the dentist, whether or not you've been to the physician, what health issues you have, things like that. And some of those epidemiological studies, I mean, they're massive in scope, and they just take a long time to process. So some of the numbers in here are a bit older. I try to update them when they come out. So some of these are older, but what I want you to keep in mind is, like, generally speaking, the rough percentages in here are like roughly how much of the population has perio. Okay, does that make sense? Okay, so when we get done today, you should be able to define periodontology. Okay, so I used to have this earlier in the semester, but then I started putting clinical stuff first. So if you're thinking like, wow, like we know that already, wonderful. I'm getting back to some of the essential nuggets now that you know how to do what you need to do with patients. Okay, so you should be able to define periodontology and epidemiology and discuss its place in the world of dentistry. You should be able to define prevalence and incidence and know the difference between those two. So I'll ask you to apply those terms on the test. And you should be able to differentiate between severity and extent. Okay, we've talked about severity and extent already, so some of this should be review-ish, right? So you should be able to describe what an index is and discuss why they're prevalent in epidemiological studies. Okay, so the PSR is an example of an index. You should be able to list the criteria of a good index, okay, and provide examples of the different types. So we're going to have perio indices, gingivitis indices, calculus indices, and we'll go through a couple of examples. You need to know which ones of those measure which things, okay? Shoot, chronic perio and aggressive are showing up here too. Okay, we're going to talk about those. I think I edited them out in the PowerPoint, but I missed them in the objectives. So you need to be able to define gingivitis, and we'll talk about the difference between chronic and aggressive perio and how they show up in our classification system today. You should be able to define a risk indicator and a risk factor and be able to differentiate between the two. Okay, for the most part, when people talk about risk factors for perio, they don't call risk indicators and risk factors. They call everything a risk factor. So we're going to differentiate the technical difference between these two today, and then when we talk about risk factors for perio, we're just going to call everything a risk factor. So I want you to know that they're technically different things, but because everyone calls it risk factor, that's how we are going to discuss it from here on out, okay? All right, so periodontal disease, what is it? It could be a whole range of stuff, right? It could be gingivitis, it could be periodontitis, it could be just where you've brushed that one area to death and you've totally killed the bone there. It's a whole scope of things. So everything in that whole AAP classification system counts as a periodontal disease. One thing I want you guys to be aware of is that when you're out and about in the world, people say periodontal disease when they mean periodontitis. Okay, so periodontitis is a specific type of periodontal disease. Okay, if you've got toothbrush recession, that is not a healthy periodontium. It's a type of periodontal disease, but in the everyday, day-to-day practice of dentistry, most people call periodontitis periodontal disease. So I need you to just be aware that people use that term specifically for periodontitis. Okay, that's how it's used, when in fact it's an umbrella term for a large scope of issues. Okay, bacteria is going to be the main causative agent, and there are other local contributory factors. So calculus is a local contributory factor, right? Because the calculus itself isn't causing the perio. It's the bacteria that live in the niches in the calculus that are driving the periodontal infection. So star, star, star. Bacteria is the causative. I love when I say star, star, star. I see everybody's fingers start doing this on the keyboard. They're like, oh, I got to pay attention right now. The main causative agent is bacteria. Okay? And then the other piece of this is host response. Okay, so some bacteria produce enough byproducts or destructive enough byproducts that the bacteria alone can cause destruction of the periodontium. However, a lot of the disease progression or that loss of attachment in tissue is from the body's immune response. So it is your body responding to that infection that is going to drive the destruction. So we're going to talk about immunology in probably way more detail than you want to in a couple of weeks. And we're going to talk about the mechanism of why this works, what chemicals do this, what enzymes are doing this, and how that process works. But your body's immune response is the other piece of this, okay? So I love this picture because of the way that they have drawn the schmutz on here. Because you've got calculus, so this is like for patient ed materials, right? So like, have you ever noticed this? We call it calculus, but we have to call it tartar when we talk to patients because that's what people in the outside world call it. And if you say calculus to people in the outside world, their first thought is math calculus because that's their that's how they've interfaced with it, right? So, but you've got your calculus on there. It's got wonderful bacteria in those niches, and the gingiva are inflamed. They're red. They're puffy. Got an open contact here, and we've got a reduced bone height. Okay. So periodontology, or periodontics, as it's sometimes called, is the study of periodontal disease. Okay. And epidemiology is the study of health on a population basis. Okay. So epidemiology is when we are looking at the health of an entire population. So, you know, epidemiological studies look at a national sample or look at a large sample of patients because they're trying to get a scope of how much disease do we have, you know, on a wider playing field. So when we have research in the fall, we always watch a movie on the first day of research class, and it's called And the Band Played On. So if you've seen it before, you get to see it again. But they do a lot of epidemiological studies, and you kind of get a good insight into what epidemiology actually is when we watch that movie. But broadly put, it's studying health and disease on a population basis. And a lot of what we know about periodontal disease comes from population surveys, so looking at some of those epidemiological studies. Okay? So two of the terms that you need to know are prevalence and incidence. Okay? These are quantitative values. Okay? So it's driven by numbers. So quantitative means that we can apply statistics to it. It's driven by numbers. And when we can numerically examine data, it's quantitative data. Okay? So that's what quantitative means. Versus qualitative. Qualitative is when we're looking at words and text and using the words in the text to draw, you know, to pull out themes and draw conclusions that way. In the health sciences, most of our research is quantitatively based. Okay? Prevalence is the number or the proportion of the population that has a disease. Okay? So at any given time. So we could take a non-perio example if it helps. So this would be like the number of people in the United States or the percentage of the population in the United States who has AIDS. Okay? So that's prevalence. It's just at any given time, how many cases do we have? Incidence is the number of new cases over a specific period of time. So that would be the number of new cases of HIV over the course of 2018 to 2019. Okay, over one, you know, calendar year or one academic year, how many new cases do we have in that specific period of time? Does that make sense, the difference between those two? Total number versus number of new cases over a specific period of time? Okay. So, as a side note, if you're ever looking for information on where we are, state of things, for systemic health issues, like the CDC has a ton of population health information, including CDC and NIDCR would probably be your best place to go if you're interested in just straight up numbers for oral health issues. Okay. It's going to be a specific number of cases over a specific amount of time. Mm-hmm. Right. It's usually a specific number. Mm-hmm. Usually, because it's a little easier to understand. You might see it as a % increase, but I think most often is presented as a regular number. Severity and extent are two of the things that we look for to describe perio. So you tell me, we've talked about severity and extent. What is severity? How bad it is, right, in terms of how much bone loss is there, right? Vertical height, vertical dimension of bone loss, okay? Is it just a little bit of bone loss? Is it a lot of bone loss? So vertically speaking, how much root structure, how much root support have we lost, right? Extent is how widespread is it in the mouth? How many teeth are involved, okay? Is it just a few teeth, or is it, is it less than 30%? Is it 30% or more, okay? So, in thinking about these things, how do we figure out what severity and extent is? How do we know what we're looking at in a patient? You're going to look at radiographs. What else are you going to look at? Probing depths, and recession, right? So we're going to look at radiographs. We're going to look at perio charts. So here at Pacific, we do a complete periodontal exam, okay? Anytime you're doing assessments on a patient, so not at screening. I think during screening you just do a quick one, but in a regular patient appointment series, you're going to be doing a complete periodontal chart, okay, complete perio exam. I'm not sure exactly what they do during screening appointments, but I think it's abbreviated, okay? But let's say, hypothetically, you're doing an epidemiological study and you want to look at 1,000 people. What kind of periodontal exam are you going to do on those people? You're going to do a complete periodontal exam on 1,000 people? You're like, I hope not. No, you're going to do a screening of some kind, because studies are expensive. Because you have to pay your examiner, you have to pay the person, you have to pay all of the people who are on the study. In most instances, this is like teams of researchers at a university, and at a big research university, the way it works is often the people who teach there are required as part of their job to get a certain percentage of their salary in grants. So then that percentage of their work is dedicated to research. So it's part of their regular pay. But in the scheme of things, you still got to get that money somewhere because the work has to happen. So since research is expensive, if you're trying to examine 1,000 people, we got to find a better way to do this, or at least a faster way to do this, because we don't have time, right, to practically do a complete periodontal chart on 1,000 people. So this is where indices come into play. Okay, so the single version is index. Okay, index is single, plural is indices. And I always get tickled when I hear people say indice. It's like one indice. That's not quite right. But if you say indice, I know what you're talking about. And I'm not going to pick on you openly, verbally, okay? So, but indices are the screening tools that have been developed to allow us to kind of get an idea quickly, a little more quickly, of what's going on in the mouth, okay? So oftentimes indices are used in epidemiological studies because, as we've talked about, it's just not practical to do a complete perio exam on 1,000 people, okay? So our indices, now these are important. I want you to kind of star this slide, not only for this class, but as you're getting ready for boards. National boards have from what I understand, it's different for everyone. But roughly speaking, there's a large portion of the national board now that's dedicated to public health. And public health and indices you're going to see on there. So you're going to need to know, you're going to do indices in public health as well. We're going to talk about a few in here, but in public health you talk about like 20 different indices. So you need to know what they're looking for and how they work. So this list of criteria you may be seeing again later, I don't know, right? So we don't actually get much information at all as to what's on the national board. That is very closely held information. But if there's a large public health focus, I'm betting these are on there, so I would pay attention to these. The criteria for indices, it should be easy and fast, right? If the index is super confusing, the risk of examiners getting it wrong is high, okay? So it needs to be pretty simple to use. It also needs to be fast, okay? If it takes forever, we may as well do an entire screening, right? It should be sensitive, meaning that it's actually going to measure what it's hoping to measure. So if it's an index to measure periodontal disease, it should be able to detect periodontal disease. If it's not actually picking up disease in a person that has it, it's not sensitive enough. Sensitive means it has the ability to detect the disease it's looking for. So it needs to be able to do that. It should be valid, which means it's measuring what it's intended to measure. So an example of a problem with validity would be like if you had, let's say you were doing a study and you wanted to study plaque in your patient population. And what you want to know is how much plaque do these people have, and rather than using a plaque index which measures plaque, you use a gingival index which measures gingival inflammation. Okay? So whatever index you're using should be measuring what you intend it to measure. Okay? The indices that we have in here have been validated to measure what they're supposed to measure, so that's good. Okay? Reliable means that it performs the same way consistently over time. So if you had the same person in your chair 3 or 4 times or with 3 or 4 different examiners, it should be easy for all of them to score that individual in the same way. Okay? Level of risk should be acceptable to patients. Okay? This one seems like a sort of like, well, of course it should be. There's one index that you're going to learn next year, the Eastman Interdental Bleeding Index. And with that one, you take like a toothpick and you kind of press on the interdental gingiva like 3 or 4 times and then wait to see if it bleeds. I haven't ever seen it used in a study, but it's out there. And that anytime I see this, like the risk should be acceptable to patients, I'm just like, I may not appreciate that one done to me. Poke, 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 poke. It's bleeding. That one's bleeding too. That one's bleeding too. It's like, of course it's bleeding. You poked it. They should be amenable to statistical analysis. Like the whole idea behind these is that we can screen a lot of people and then we can run stats on it to see where we stand. Okay, so if you can't quantify them or reduce them to numbers in some way, they're less than useful. Okay? And they should be clinically significant. Like if it doesn't measure anything significant clinically, it's like, what are you doing? Why waste the time? Okay, so let's talk about a couple. Okay, what plaque indices are you using in clinic now? Did you guys do plaque indices in the fall? Do you know which plaque one you're doing? Tursky, Quigley-Hine, plain plaque index, Selness and Low, plaque index, regular plain plaque index. Cool. All right. So there's a lot of different plaque indices. Okay, we hygienists love our plaque, and dental researchers do as well. So here are your examples. So the O'Leary is one, regular plaque index by Selness and Low. I think this is the most common one because it's pretty simple to use. It's like a straight up percentage points of areas that have plaque on them, right? So it's a little easier. Simplified debris index, okay? And there's the Tursky modification of the Quigley-Hine, okay? I just like the plain old PI. it's a little easier, okay? But all of these measure, you know, presence of plaque, thickness of plaque, or distribution of plaque, okay? Some examples of calculus, there's a simplified calculus index, the Volpe-Manhold, and calculus index of the NI, this is now NIDCR. It's National Institute of Dental and Craniofacial Research, was renamed several years ago, but I don't think the name of the index has changed. And all of these are going to measure the extent of calculus, okay, and location of calculus. Okay. So I just need you, for right now, I just need you to know that these are examples of plaque indices, these are examples of calculus indices, and these are examples of gingival indices. I don't need you to know how they work right now, other than PSR. You guys know how that one works. You do need to know how that one works. But for these ones, I just want you to know these are some indices that are used for that, and which ones do what. Okay. Gingival index, I think you guys use this one as well, right? Modified gingival index and the sulcus bleeding index. And I kind of told you, gave you a heads up on the EIBI one. So whichever ones of you do EIBI next year, have fun. Because the way we've been doing it the last several years, and I don't know what they're doing this year because I'm not teaching public health anymore, but when I was teaching public health, I had student teams each present an index. So it wasn't me presenting 20 indices in one day, because we think everyone would want to just walk off the edge of a building if we had to do that. So if they're still doing student team presentations on that, have fun. Whoever has EIBA, it's really hard to get through that one without laughing. Periodontal indices, there's a periodontal index, community periodontal index of treatment needs, or the CPI. Sometimes it's called CPI-TN, sometimes it's just CPI. They can break that one down into two subcategories. Sometimes they leave the treatment needs off of there and just do the periodontal index part. And PSR, which you guys will be doing and actually practicing tomorrow. So have fun. All right. So are we doing okay so far? Feel good with prevalence? Feel good with incidence? Cool. All right. So if you think about back in the day, okay, so this is a long time ago, dentistry is very preventive now, right? Like, we go every 6 months, we get our teeth cleaned. If you have a small cavity, we go ahead and get it filled so it doesn't become a big cavity. Dentistry is very preventive in nature now. It wasn't always that way. So if you think, like, 100 years ago, people didn't do anything until something was hurting, and then mostly they just got it pulled, right? So historically, periodontal disease was considered just part of aging. It was normal. You were expected to lose your teeth, So they thought, everybody's going to have perio, and if you think about it, it was logical, right? Because they probably weren't doing the type of preventive care stuff that we do now, right? Like, people maybe didn't floss, or maybe didn't brush, or, I don't even know when the first toothbrush was invented. I don't know, but it was probably a long time ago. To give you guys, I think I told you guys this already, maybe not, to give you guys a more recent historical example. So I grew up in rural North Carolina, okay? And I grew up in a house across the street from my grandmother's house where my mom grew up. When my mom went to college, her roommate was an orthodontist kid from Raleigh, okay? My mom had never seen dental floss before. She didn't know what it was. No one had ever recommended dental floss to her. And she asked her roommate, she's like, "What are you doing?" My mom's not that old. Okay, my parents are 62. So they're not that old. But for someone who's my mom's age, who grew up in rural North Carolina with an old school dentist who was old, she had her fillings done with no anesthetic because her dentist didn't believe in anesthesia. They only went when something was wrong. So my mom's not that old. It hasn't been that long ago that was dental reality for a lot of people. So just giving you some scope, okay? So historical perspective, everyone lost their teeth. It's just part of getting old. You just didn't have anything at the end of your lifespan, right? Now, it's not that way anymore, okay? People keep their teeth for a lot longer. I had I don't think we had any patients in our practice who didn't have any teeth. Because if you don't have any teeth, you're probably not being seen in a general practice. So that's pretty logical. But I remember my grandfather, he died when I was really little. He died at 61. He had full dentures, top and bottom. And I have older relatives who had full dentures, top and bottom. And it was pretty common for people to just have dentures. Like, that was just a regular thing, like an average normal thing. And now we have people who are keeping their teeth much, much longer. I went to see my grandparents over Christmas, and they're 92 and 93, and both of them still have all of their teeth, which I thought was really cool and amazing. So I'm hoping that my dental genes come down from their side. Today, we don't consider it part of aging, but it's just a complex process, right? Like, it's partially driven by bacteria, it's partially driven by immune response. We do see more perio in older populations. Okay, we do see more of it in older populations. But if you think about it, that's also logical. They've been around longer. They've had more time to build up more bacteria and more calculus and have had time for more of that destruction to occur. So it's logical to see more of it in our older populations, but it's not considered part of the normal aging process. Okay? So I have these on here. Okay, so gingivitis is just inflammation in the gums, no loss of attachment, no destruction of hard tissues. Periodontitis is once we've started losing those hard tissues. Okay, so with loss of attachment. Okay, so during the 2012 NHANES round, about 48% of adults, almost half, had periodontitis. Okay, so if half of the population, half of the adult population has periodontitis, should you realistically be expecting to do prophies all day long in your practice? No. Okay. Might you be doing prophies most of the time? Maybe. Depends on what type of practice you have, right? So it's a lot of times we see disease spread along the socioeconomic spectrum. Is kind of a predictor, right? So people who tend to be in a higher socioeconomic spectrum have had better care, have had more preventive care, and they tend to have less disease than people along the lower end of this SES, okay? So in the scheme of things, at this time, about half of the population had perio. About 9–10% of people had stage 1, 30% had stage 2, and about 10% had stage 3 to stage 4. Okay. I have the old descriptors in here of mild, moderate, severe, because I think people are still going to be talking about it in that way when you get out of here. And so I want you to be comfortable with the new classification system and with the old verbiage. Okay. And it's going to be different by population. Okay, it varies. So men tend to have greater severity in periodontitis than women. Black and Hispanic males tend to have a greater incidence of perio than white males. And then we tend to see a greater incidence in those of low socioeconomic status and those with less than a high school education. Okay, so spectrum of disease with socioeconomic status is kind of, it's definitely there for dentistry. It's also there in other areas of disease as well. Okay. Tobacco use is a big one. Okay, so 64% of smokers have perio. Yes?
So what's the difference between chronic periodontitis?
Chronic periodontitis is like regular perio that progresses kind of at the expected rate. Aggressive periodontitis it is when you have disease that's rapidly destructive. So what's typical in aggressive perio is some form of immune dysfunction. And you're going to see a really rapid rate of destruction and often a molar incisor pattern of destruction where you have like severe bone loss in the incisors and around the molars specifically. So chronic and aggressive were the two primary periodontitis labels in the old labeling system. Those labels aren't there anymore, but you're going to continue to hear about it in that way. So now I want you to think of aggressive as grade C. or aggressive would fall into grade C. Other people are going to fall into grade C that don't have what we would traditionally think of as aggressive perio, but that's where it would hit now. Okay, so here's where we're going to talk about the difference between risk indicators and risk factors. Okay, so risk indicator is like a demographic type thing or behavioral characteristic that is associated with higher rates of disease, okay? Not causative in and of itself, okay? Just because you're male doesn't mean you're going to have perio. It doesn't work that way. Okay, just because you're low socioeconomic status doesn't mean you're going to have perio. It doesn't work that way. They're not causative, but they're demographic characteristics that tend to be associated with that disease. Does that make sense? Okay. So some of the risk indicators for perio are going to be age, level of education, gender, or sex assigned at birth, not gender identity, but gender assigned at birth, and race. Some of the risk factors are things that have been shown to possibly put someone at increased risk for developing. So it's predictive, but it's not necessarily causative. So like calculus, diabetes, tobacco, smoking, these are risk factors. Okay, so things that biologically it's plausible that they can increase your risk of perio directly. So demographics scientifically don't have anything to do with perio. It's more of a what we just tend to see within the population. Risk factors can cause a change in your health, right? All right, so the two biggest things I want you to remember when we're thinking about risk factors for perio are going to be smoking and diabetes. Okay, those are widely recognized to have direct impacts on the progression of perio, and they're both reflected in your grading paradigm, right? So just keep those two in mind. So epidemiological studies have really helped us better understand the way that the disease is spread through the population. Okay, so like we wouldn't know necessarily that, you know, people of lower socioeconomic status or different races, different genders would have any difference in experience of disease if we didn't do those epidemiologic studies, right? The epidemiological studies also help us plan programs. What they allow us to do is they allow us to get a snapshot of what the health is in the population at large, and then to say, okay, are people able to take advantage of the programming that's out there? Or do we need to make a change in the system so that things are more accessible for people? Okay? We're in an upswing on the preventive front in dentistry. Things are continuing to get more conservative, which is really good. So like, you know, 6 years ago, we didn't have silver diamine fluoride in our Practice Act. Now we have silver diamine fluoride in our Practice Act. Do you guys know what that is? Okay, cool. So, you know, the way that we are approaching dentistry is becoming more and more preventative. Okay, so, and I think as we continue to shift in this way, hopefully things will continue to improve and maybe we'll be more in demand as hygienists. One thing that's exciting is that our scope of practice is changing. Hygienists are gradually getting more and more things we can do, and with the implementation of the mid-level dental provider, I mean, dental therapist is accepted in like 6 or 7 states now. So we're getting there. Okay, so it's becoming more and more, the scope is changing. It's really cool. Okay? So here are our keys. Okay, epidemiologic studies give us insight for large populations. They let us know where we stand. And the indices are what we typically use in those types of studies to make those studies feasible. Okay? Gingivitis is going to be the most common form of periodontal disease. A lot of people have gingivitis. Okay? Lots and lots and lots and lots. Periodontitis is prevalent in the population. If about half of adults have perio, that's prevalent, right? Okay. And risk factors are used to predict occurrence and probability of disease. They're not causal. So not every smoker is going to have perio. Most smokers will have perio, but not every single one. Okay, and that has to do with host response and how that person's individual combination of factors is coming together around disease. So risk factors can help us predict disease, but they're not necessarily causative. Okay? What are the two biggest risk factors we need to keep in mind for perio? Smoking and diabetes. Very good. Okay. What questions do we have? Yes. Uh-huh. Yes, so that's a really good question. To clarify, periodontal diseases, okay, periodontal disease is an umbrella term that captures everything that is in that AAP classification. That is not a healthy intact periodontium. Periodontitis is that active loss of bone height. In practice and in that clinic, people are going to use the term periodontal disease to mean periodontitis. They use them interchangeably. Technically, that's not correct. In a practical sense, that is how people use that term. So that's what most people mean when they say periodontal disease. But technically, it's an umbrella term for a whole lot more than just periodontitis.
Do they use periodontal disease because like maybe the patient will know more?
Could be that. It could be that most people aren't nerds and dig into the weeds that much. And mostly our life is, you know, healthy gingivitis, periodontitis. That's like where 95% of our population lives. And so that's, when that's all you're doing most of the time, that's kind of where your mind goes. So I think that's what it is. But I just want you guys to be aware, like technically that's not the right term. Periodontitis is the right term. And where people tend to get confused is they'll be like, toothbrush recession is a really good example, right? Because like in toothbrush recession, you've lost some ground. You've lost some real estate. It's not a healthy periodontium there. But it's not periodontitis. So I remember one time a faculty member saying, so my daughter has a ton of toothbrush recession, and you're telling me she's got periodontal disease. I'm like, yes, it is a periodontal disease. It's not periodontitis. But it's not an intact, healthy periodontium either. She's lost real estate. You can't look at it and say it's healthy because the bone, the gingiva, everything is gone there. So that's the difference. Does that make sense? I would put whatever's in your chart note, I would put the specific classification that they are, because you want your chart note to be very specific, because that's your legal documentation. You may have a culture in your office that people just talk about it as periodontal disease, because that is easier for the patient to understand. So whatever you say verbally, it's probably going to just fit with whatever the culture in your office is. But for your chart note, for sure, you want to say periodontitis. Mm-hmm. Good questions. These are all really good questions. Anything else? Okay.